So let's start. The following serum biochemistry results were obtained from a 58-year-old female with subarachnoid hemorrhage. Sodium 172, which is high. These are the values, 135 to 145. Potassium 4.3, which is normal. Urea 18.3, which is quite high. Creatinine, normal. Glucose, so this is the random blood glucose. 5.3 is normal, and then 24-hour urine is 4.6, which is quite high. So the first question, what are the biochemical derangements in this set of values? So you can answer in the chat. What biochemical derangements do you see? Hypernatremia, yes. So hypernatremia here. Which other one? Hypernatremia, polyuria or diuresis, yes. I'm seeing hyperuricemia. Yes, so the urea is high. Polydipsia. Polydipsia actually means drinking a lot of water. So from these values, you can't see polydipsia. So you see polyuria. So polyuria is poly means a lot, then urea is urine. So a lot of urine, water in urine. So that's polyuria. So the main ones are hypernatremia and polyuria. Okay. So possible causes of this. Then one thing I want you to see is the patient is a 58-year-old female with a subarachnoid hemorrhage. So before you start saying any story of kidney failure, one thing you have to remember is most likely this is a comatose patient because she came in with a subarachnoid hemorrhage. And these derangements most likely are caused by the fact that she's dehydrated. Okay. So these high levels of urea is caused by the dehydration, not any kidney issue. So like kidney failure that you expect, high urea concentration, okay? So possible causes. What are the possible causes here? What of urea? Yeah, urea is high. But if you ask the main, go with the sodium, so hypernatremia and polyuria, because of this high volume of 24-hour urine. Causes, central diabetes insipidus, yes. Central diabetes insipidus. So I have a picture here to differentiate between central and nephrogenic diabetes insipidus. I want you to see here. So let's start with the central one. So for central diabetes insipidus, our issue is at the pituitary gland, okay? For nephrogenic, our issue is at the kidney, okay? So let's start with central. For central, we know that, okay, before I go to central, let's just start with the pathophysiology of the whole diabetes insipidus. So what happens in diabetes insipidus? We have this, let me zoom in. We have this ADH. ADH, what's the function of ADH? To reabsorb water. So the ADH will bind to these receptors. So these receptors are the V2 receptors, okay? When the V2 receptors are bound to, when the ADH binds to the V2 receptors, they'll cause the formation of this aquaporin 2. Aquaporin 2 on the surface of the cell. So this is the lumen where the urine is, this is interstitium where the blood is. So aquaporin 2 facilitates the movement of water, okay, from here, the lumen or the collecting duct, back into the blood, okay? So this is a reabsorption of water. So that's the mechanism of ADH. Now, in diabetes insipidus, you can either have reduced pituitary ADH secretion by the pituitary or reduced renal ADH sensitivity, basically ADH resistance. So the fact that ADH will bind here, but it will not cause formation of this aquaporin that will lead to the reabsorption of water. Okay, so that is nephrogenic diabetes insipidus. For central diabetes insipidus, the ADH secretion is just impaired. Now you won't have ADH to bind to the V2 receptors to cause formation of the aquaporin. So that's central diabetes insipidus. So I hope you've understood the difference. Other lab tests to be performed. What other lab tests to be performed and what are the expected results? So plasma osmolality. So what is osmolality? Can I get someone from the chat to tell me what osmolality is? What is osmolality? I want to see answers in the chat. What is osmolality? Yeah. So amount of solute or concentration of solute. Yes, so that's osmolality. Yes, so osmolality, we use the liters, osmolarity, amount of solute per kg. So we usually use osmolality. So plasma osmolality will be high, urine osmolality low. So basically what this means is, remember in this patient with central diabetes insipidus, the volume of urine is 4.6 liters, which is very high. So the amount of solute in the urine will be very low. There'll be huge amounts of dilute urine. For the plasma, we expect it to be high. Why? Because we are losing so much water in the urine, making the plasma have more concentration of the solute. Okay. Outline the next steps of management in this patient. Administration of desmopressin. So, what is desmopressin? Desmopressin is an ADH analog. So, remember this patient has central diabetes insipidus, so meaning they have reduced production of ADH or reduced release of ADH. So if you give them an analog, it's going to work. And then administration of adequate fluid. Okay. And then you have to remember desmopressin is administered intranasally. Yeah. So basically, this is how the question will come. You have to interpret this and then you answer like that. Yeah. Then we have another question here. Okay. A 37-year-old female presented with a 3-month history of polyuria and nocturia. So polyuria is the huge amounts of dilute urine. Nocturia is actually waking up to go pee. So peeing at night. So when you're asleep, you go wake up and pee. It's also known as nocturnal enuresis, or you actually pee on yourself at night. Okay, so you either wake up and go pee or pee on yourself. She claimed to drink 14 to 18 glasses of water daily. Water deprivation test with vasopressin was done. Results are shown below. So we have plasma 292, urine 72. So it was measured at 7, 8, 9, and 10. You can see the urine concentration is increasing. Now it's not consistent, 78, 76, then 85, not consistent. Then intranasal ADH is given, as we said. So the desmopressin measured at 12, it was 294, but the urine, it became 814. At 1, 295, and then 998. So who can tell me, what does this say? What is the diagnosis of this? Number of osmoles per kg. Oh, I'm assuming this was the osmolality question. Yeah, so number of osmoles per kg, osmolality, then osmolarity, number of osmoles per liter. Yeah. So diabetes insipidus, diabetes insufficiency of SADH, SIADH. Really? Okay. So let's interpret this. I'm seeing a variety of answers. So let's interpret this. Okay. So this patient has polyuria and nocturia, isn't it? And then when given vasopressin, the values skyrocket of the urine. So one, we can tell here that they had high concentration, low concentration. Osmolality was low, 72, 78, 76. So this means that their urine is very dilute, which has a low concentration of the solute. But when you give them ADH, the concentration increases. So what does this mean? That the person absorbed, ADH worked, and a lot of water was absorbed. That's why the value skyrocketed, okay? So this means that the urine output was decreased and the osmolality increases. So what do we call this? What do we call this? This is central diabetes insipidus, okay? This is central diabetes insipidus. Basically, this person didn't have production of ADH, because when you gave them the ADH, we can see that it worked, okay? So we can look at the reasoning. This is because the urine osmolality returned to normal range. Hence, the issue was with ADH production in the hypothalamus or pituitary release stroke secretion of ADH once ADH was given. So I hope you've understood this. You'd be given this, maybe you'd be told, what's the diagnosis? Giving reasons, what's the diagnosis? So you'll say, central diabetes insipidus, okay? Understood? I have another chart. I'll compare them with the others. So like, for example, nephrogenic and chronic polydipsia. We'll see there. I'm seeing someone is asking, what's the normal osmolality range? So you guys tell me, what's the normal osmolality? So give me in urine and in plasma. You guys type on the chat, give me the normal osmolality in urine and in plasma. And then another question, how come plasma osmolality doesn't change by much? So the plasma osmolality isn't constant because one, what's the function of ADH? So ADH is to reabsorb water from the urine back into the bloodstream. So our main cause here was the urine. What we are actually looking at is the urine. Urine is the one that will be reaffected because remember we are reabsorbing this water from the urine. So a lot of solute remains in the urine. So that this is what will be mostly reaffected. But for the plasma, you can see it slightly increases, but not that much. Yeah. So urine, someone has responded. So urine is 500 to 890. And then plasma 275 to 90. Okay. Yeah. 275 to 290. So it's increased slightly. Describe the biochemical test you'd expect in such a patient. So for the biochemical test, I want you to tell me in terms of urine osmolality, sodium levels. So if it's plasma sodium levels or urine sodium levels, you can also tell me about the ADH. The ADH. So comment on the, let's start with the urine osmolality. Do we expect it to be increased or decreased in this patient with central diabetes insipidus? Decreased, yes, good. Sodium levels. Sodium levels in plasma. Let's start with plasma, then in urine. So increased in plasma, yes, and then in urine, decreased in urine, yes. Yeah, I can see you guys are understanding. So let's see. So decreased urine osmolality, yes. Decreased urine sodium levels, decreased plasma ADH, yeah, because we have central diabetes insipidus, so this is obvious. Increased plasma sodium levels, so we expect hypernatremia, and then increased serum osmolality. So I hope all these 1, 2, 3, 4, 5, all these 5 make sense. Okay. Then state the main clinical features. So clinical features of central diabetes insipidus, state for me 4. So I can give you 1. Polyuria is 1. Any other clinical symptom in central diabetes insipidus? Nocturia, yes. So thirst, so excessive thirst, polydipsia. And then one more. Dehydration, yeah. So severe dehydration in case of low water intake. So you'll have altered mental status, lethargy, seizures, coma, hypotension, etc., etc. Then one thing to note is if the urine osmolality was still low, so yeah, after administration of ADH, it would be nephrogenic diabetes insipidus since the kidney cannot utilize ADH or ADH resistance. So let me explain this chart. Okay. So let's start with this. So you have a serum of 283 to 293. then a urine of 750. Then if you give them the DDAVP, which is desmopressin, it's greater than 750, this is normal. This is a normal response because we know we expect desmopressin to reabsorb the water. What will happen is it will be greater than 750, which is normal. But now, when you have a serum greater than 293 and a urine of less than 300, but if you give them desmopressin and the urine osmolality hasn't increased, what will happen is this is nephrogenic diabetes insipidus. So basically here, there's ADH resistance. The body is not responding to ADH. Higher. If you have greater than 293 for the serum, less than 300, but if you give them desmopressin and you increase till like 750, almost to the normal range, this is central diabetes insipidus. So as we had seen in the earlier, in this patient, the above patient, higher. Serum less than 293, urine between 300 to 750, which is normal. And then you give them the ADH, the desmopressin, and it is less than 750. So here it's less than 750. This is chronic polydipsia. Well, basically what chronic polydipsia is, chronic polydipsia. So this is a person, we usually refer them to, there's a name we usually give them. These people who drink a lot of, water due to psychological reasons. They're actually not sick, but they just drink so much, they drink too much water. Yeah, so this is the chronic polydipsia. So this is how you differentiate between chronic polydipsia and the rest. These are the values. Okay. I'm seeing a question. Can you repeat why serum osmolality doesn't change significantly? Oh, here. So as I said, here, when you give desmopressin, we reabsorb the water, isn't it? We reabsorb the water, isn't it? So when we reabsorb the water, we expect these ones to rise. But when we reabsorb the water, we expect the osmolality of the urine to rise, isn't it? Because there's a lot of solute remaining. As the water goes back to the plasma, the changes are not with immediate effect compared to the urine. You can imagine, let me give an example. Taking water, let's say you have salt, a salty water, then you boil it. You'll expect the salt to remain. But now you put this water in a bucket already containing salt. So the process isn't as rapid as you compared with the one for the urine. Okay, so we'll expect it to increase, but not that rapid compared to that of the urine. Okay. So I'm seeing another question. What is the management of nephrogenic diabetes insipidus? Yes, so anyone in the chat who knows? Anyone in the chat who knows? Yes, so thiazides, yes. So you can use thiazide diuretics. What else? Amiloride, yes, you can use amiloride. And then NSAIDs, yeah. We can use NSAIDs. Okay. But mostly for nephrogenic diabetes insipidus, I'd say there's acquired causes. So for example, if you take a drug like lithium, what else?